All right, starting up again, there's just a little bit more in this section, but starting back now at the symptom angle, we talked about diseases where you have a constellation of findings, history, physical exam, chest x-ray, other lab tests, and you actually we talked about the disease itself. Now, most patients don't come to you and say, I have COPD or I have asthma. Well, some of them will, but otherwise they come to you with a symptom, so that's your starting point. So the very common chest symptoms are cough, dyspnea, hemoptysis, wheezing, chest tightness, chest pain, and those are some of the most common basics that you'll deal with. Persistent cough, I think Dr. Morales actually talked about cough, so we'll just touch on that only briefly. And remember that your thoughts about what's likely to be wrong will be influenced by the patient population, so that if you have a healthy non-smoker, and if at some point you get a chest x-ray, which you're likely to do for persistent cough. So we're not just talking about somebody who said, well, I had the sniffles and I've been coughing for 3 or 4 days, but someone who coughs for several weeks or more. Then asthma, gastroesophageal reflux, or laryngopharyngeal reflux is another name for it, and postnasal drip syndrome or upper airway cough syndrome is another name for that, are some of the most common. So the 3 of these together plus combinations of these account for most of the persistent cough in healthy non-smokers. But as we mentioned, a variety of other conditions can present with a persistent cough. So that's one of the reasons why you've probably been taught, the warning signs of cancer and other things, that patients, if they do have a persistent cough, should see a physician. It may turn out to be something very benign and mild, like one of the things in the top, just an upper airway cough, postnasal drip, but it could be a marker of a serious condition. It could have chronic bronchitis, tuberculosis, lung cancer, and many inflammatory lung diseases, such as sarcoid and pulmonary fibrosis, will present with a cough. So since your exam could be normal, a chest x-ray becomes a very important part of your evaluation of a patient who has a cough that does not go away. Dyspnea is extremely common, and again, most common complaint is dyspnea on exertion. That's not just with COPD, but most of the dyspnea, not all, but most of what patients describe, they talk about it happens when they exert themselves. So very common diseases associated with that are COPD, CHF, and a lot of the fibrotic pulmonary diseases. Other more unusual diseases include pulmonary hypertension, which is more rare. Now, dyspnea on exertion is a common symptom in normal deconditioned people. So one of the things you're trying to do when someone says, oh, I get short of breath when I climb up the stairs or when I try to hurry to catch the bus, is you're really embarking upon a process to determine whether this person is basically healthy and just out of shape and deconditioned, which is a common problem, or whether that patient has a serious underlying disease. And it's not uncommon to have to do quite a lot of investigation to be completely sure, so that a history, complete exam, chest x-ray, pulmonary functions, and some measure of oxygenation or gas exchange can be necessary in these workups. So sure, if you, with your history, physical, chest x-ray, and pulmonary functions, feel that you have made a firm diagnosis of COPD, and perhaps you have pulse oximetry to show that the oxygen level is in the normal or near normal range, then you can stop there. But because some of the other illnesses are more subtle, you may have to go further. Now, dyspnea can be acute, and there's what I call really acute dyspnea, which means a person is fine 1 minute and then just over a few minutes has this sudden onset of shortness of breath. So these patients will commonly come to the emergency department if it's severe enough. Acute pulmonary embolus is one of the things we always think of. Pneumothorax. This could be iatrogenic. If the person's in the hospital, they might have had a procedure that could cause a pneumothorax, or a patient with an underlying disease like COPD or asthma is prone to a spontaneous pneumothorax. And there is a certain percentage of healthy young people that would have a pneumothorax and present to the emergency department, as well as we talked about a lot of lung diseases are susceptible to pneumothorax. The other thing that can present as dyspnea that you don't really think of at all as a lung problem is acute myocardial infarction or acute coronary ischemia may cause sudden shortness of breath. Asthma, so an asthma attack typically after an exposure, so that a patient may say, oh, I was mowing my grass and then I got suddenly short of breath. So that an asthma attack can develop rapidly in certain patients. If someone has a problem with swallowing disorder or inability to coordinate their swallowing, they may aspirate, and that can produce an immediate either laryngeal inflammation and irritation, or inflammation, irritation in the large airways, or an actual severe alveolar process from aspirating gastric acid or other stomach contents, and that can cause very sudden shortness of breath. Also, an anaphylactic allergic reaction can occur over just a few minutes. Hemoptysis, coughing up blood, is something that very appropriately people take seriously, because it can be a sign of very serious underlying lung disease. Now, I put as the first thing that, in fact, most of the patients turn out to not have something bad if they have mild hemoptysis. So acute or chronic bronchitis, typically, not always, but typically in a smoker, may have hemoptysis that's benign. But your mission is to find out whether this is benign hemoptysis that's just due to some irritation and will go away, and you tell the patient, oh, don't smoke, or whether they have something more serious. So the more serious illnesses like pneumonia, which is of course treatable, lung cancer, tuberculosis, acute pulmonary embolus, or all of the fibrotic scarring diseases can actually produce hemoptysis. So some of the things that are important in your history and your exam are to know whether the patient is a smoker, because that's a risk factor for cancer of the lung. And a person who smokes and has hemoptysis has a statistically higher likelihood. It either is or it isn't, but there's a higher likelihood that he could have malignant lung disease. You're interested in whether it's acute and just over a short period so that it resolves within just a few days versus persistent. So persistent hemoptysis is more worrisome because these ongoing chronic, I say chronic, but ongoing illnesses that aren't going away, like cancer or tuberculosis, would continue to be symptomatic, whereas an acute bronchitic inflammation frequently will resolve. So those are very important parts of your history. We're also very focused on whether it's massive or mild, and that in part influences the diagnosis, but it also influences what you have to do with the patient. So the patient is coughing up large amounts of blood. It's an urgent or emergent problem. The patient needs to be hospitalized because they're at risk of actually dying from the hemoptysis itself while you're trying to figure out what's causing it. Whereas mild hemoptysis, even if persistent, can usually be worked up in an outpatient setting. The chest x-ray is important because you've got a whole different list of concerns if the chest x-ray is normal versus if you can actually see an abnormality on the chest x-ray, and that might be a clue to the diagnosis. And then the exam can be completely normal or not, depending on the cause. So you'll learn further as you actually see more patients in your clinical setting, in the clinical examinations, how to try to use these different aspects of the evaluation to work through the differential. So here's just a chest x-ray grouping that kind of shows you some examples that we've talked about. So if we try to think about the physical exam findings, if we look at the picture here on the upper left, this is a radiographic picture of a left pleural effusion. So you see the, if you look at the, use the right lung as the normal lung, here you see the lung taking its normal contour, and this area down here is what we call the costophrenic angle, which you can see. And then here over on the left side, you see a radio-opaque density here, which you shouldn't see. So you've lost that angle. You have white where you should have aerated lung. And so if you percuss over this area here compared to the right side, this area should be dull to percussion. If you listen, particularly at the very lower parts, you should have very diminished breath sounds, and that may be over much of the effusion, or in the upper parts of the effusion, you may hear signs of consolidation. Now, at the bottom left, this patient has an elevated hemidiaphragm. This is interesting because the lung is in the right place, but the diaphragm comes up higher, so the abdominal contents come up higher on the left side than they would on the right. So you can see that if you're examining the patient, so if you're examining them on the right, you're percussing, and you're percussing good resonant lung all the way down. And then if you're percussing on the left, you percuss, and you run out of good lung, and you start to get, depending on where you are, if you're posterior, you'll mostly hear dullness to percussion as you cross the diaphragm. If you're percussing anteriorly with the patient sort of lying on his back or semi-recumbent, you can see that you'll actually be over stomach bubble or bowel gas, and as you percuss over this area, you'll start to get into maybe tympanitic sounds. Then if you listen with your stethoscope in the same areas, you'll hear normal breath sounds on the right, but on the left, you'll get into the decreased breath sounds or absent breath sounds as you listen. Let's put this arrow in a different direction here. So as you listen, you'll hear normal breath sounds, and then your breath sounds will diminish and disappear sooner, that means at a higher, higher up in the chest, on this side than they will on the other side. And then if we go over to the right-hand side, we have a left lower lobe pneumonia here, and we've already reviewed the signs of consolidation. So it would be dull to percussion because it's more of a fluid-filled density than air-filled lung. And you would have the auscultatory findings of consolidation. Now, you can review the medical history yourself. I include this because I think it's helpful to remember that you will, as you go along, tailor your history to some extent to the patient. So, on the one hand, you can think of taking this encyclopedic history on every patient, your very good, perfect, A+, complete history and physical. On the other hand, you'll encounter patients in different settings, maybe their follow-up visit or seeing them for a specific problem, and you'll take a focused history, and you may not ask all the same questions. In addition, if you suspect a certain problem, whether you suspect that right at the beginning or if it comes out later in some new information you have, then you may have to go back and ask more specific, detailed questions about a particular thing. So we don't always ask all the right questions the first time. If we get a clue or direction to head in, then we may tone down on that and ask more specific questions. So if you review the medical history, again, this is just a review. You're welcome to log out, but I'm going to review it for you. Medical history goes through the classic aspects that you've learned: the chief complaint, present illness, which is a story, which is a nice story in patient's words. Past medical and surgical history. Medications are very important because now our patients are on hosts of medications that can cause problems. Allergies, social history, which I use here to include occupation, so that'll be important for the chest. Family history and your review of systems. So if we think about the chest specifically, remember that we've already covered chief complaints that might indicate lung disease, right? So cough, dyspnea, hemoptysis. Then there are a lot of chest-related questions in your routine history. So you yourself ask about, do you have a cough? Do you have shortness of breath? And you'll also ask about some specific illnesses. And then you tailor or expand that for a patient that you know or suspect has a chest problem. So we mentioned some of our common chief complaints. So if we look at the chief complaint, you probably have learned this, but we're just reviewing. For dyspnea, you're trying to ask, is it exertional? Is it at rest? Is it both? Does it happen at night? And again, always, what makes it better? What makes it worse? Cough, we're asking, is it a daytime cough, a nighttime cough? Does it produce sputum? And if so, what color is the sputum? Is it a dry cough? And what triggers it? Wheezing and chest tightness, we asked about what triggers it, what gives relief. Hemoptysis, we talked about amount. And, the patient, you're going to spend a lot of time over your training and even your early experiences helping patients to quantify things. So, you can ask them, well, do you cough up an amount of blood that's like this? You can use measurements like a teaspoon or half a teaspoon if patients can relate to that. Some of them will relate better to something that's a spot of blood that's the size of a quarter or a dime. Some of them will hold up a coffee cup and you'll say, how much of this would you fill up? So you're trying to get a patient's rendering of an amount because they're not going to speak to you in cc's. Then we also ask about the duration and any associated symptoms. Chest pain, you've learned, what starts it, and then what are some characteristics. And remember, try to let the patient describe it. So try to ask, how would you describe it? Tell me more about it. And then you'll try to translate that into your writing. So try not to start off by saying, is it sharp or dull? Is it burning or stinging? Because you'll box the patient into using your words. So whenever you have something like pain, which has a potential different characteristics depending on what type of pain, try to let the patient use their terms to describe it. The past medical history and past surgical history, you will frequently try to ask specifically if they have had these diseases. So remember, sure, the patient's supposed to tell you what they've had, but our goals are to try to get the best history from the patient. So instead of just saying, oh, gee, I expect the patient to tell me if he had any of these things, if we have a patient who's got shortness of breath or coughing up blood, we'll specifically say, have you ever been told that you have asthma or COPD or chronic bronchitis? Have you ever had tuberculosis or exposure? Have you ever had any type of surgery on your chest? Have you ever had any type of injury? So you're really trying to help trigger these memories in the patient, because it's not uncommon for patients to completely forget to tell you about something in their history. In the chest history, the smoking history is very important. And again, you can review this, but we don't just say, do you smoke, but what do you smoke, when you started, when you stopped. We try to develop pack years for cigarettes, whether they're still smoking. And really, in trying to help your patients quit, remember that any effort to quit at all is useful and may indicate that the patient could be successful. So you try to encourage that by asking about whether they've quit before. The family history, again, we ask about specific diseases related to the chest. So you wouldn't just say, oh, does anything run in your family? If you're dealing with some of these illnesses, you'll ask about them specifically in the family history. Social history, smoking and many drugs, because they will lead to pulmonary reactions or pulmonary symptoms. Occupational history is quite specific and detailed, so that this comes into play significantly with fibrotic lung diseases, is the most common situation in which a detailed occupational history is needed. So this goes beyond asking, well, what do you do now, or, what did you just do? You actually will develop a list of all the jobs in chronologic order that the patient has done ever since they were a kid or a teenager and going forward. HIV exposure or risk factors, because there's so many pulmonary infections related to HIV. Travel and where the patient lives makes a difference in what in a number of infections that are endemic to certain areas of the country or areas of the world. Review of systems, again, this is probably review. So for chest diseases, there's a big focus on what we call systemic symptoms associated with certain infections and cancer. The nose is very important too. There's a connection between the nose and the lung. So a lot of questions are important to us about nasal or allergic diseases because of associations with asthma and associations with cough. The cardiac system overlaps so much with pulmonary that the symptoms of dyspnea, orthopnea, wheezing, and so forth can be either heart disease or lung disease. So we ask quite a few questions about that. Don't forget medications, and remember, I'm emphasizing again that, sure, you may have a nurse that takes a medication history. You have the patient who brings in a brown bag of medicines and you ask them all their medicines. But you still yourself will be training yourself to try to dig out from the patient clues that the patient may have forgotten, so that if you are suspecting they might have certain lung diseases or might have been diagnosed, the patient may not remember what they were told it was, but you begin to ask, well, did anybody put you on an inhaler, or do you recognize this inhaler or that inhaler, or did you take antibiotics? So you're trying to extract this information from the patient. Secondly, there are a lot of diseases that have pulmonary symptoms or pathology, so that we ask about whether they're taking medications or recognize the names of medications that might be used for heart disease, for rheumatologic diseases, or whether they're taking anti-cancer drugs. And then there are a lot of drugs that have pulmonary side effects. So just because the patient didn't tell you about a medicine, we still try to ask about common medicines that we know have pulmonary side effects if we suspect we're seeing a symptom or disease that would include one of these medication side effects in the differential diagnosis. And then finally, other data that you'll commonly need, and you'll learn more about this as you go through your clinical rotations. Very commonly, we'll need some kind of chest imaging. Chest X-ray is the simple thing to start with, but we use chest CT now for a variety of things, and there are different types of CT scans, or different ways that the computed tomography data are acquired that give different images of the chest. Ultrasound is now used for, obviously it's misspelled, but ultrasound is used for finding pleural effusions at the bedside very commonly. Also can be used to detect pneumothorax in acute care settings. VQ lung scan is another nuclear medicine type of imaging study for pulmonary embolus. Pulmonary function tests are extremely important, and as you go along, you want to remember that we don't make the diagnosis of COPD just by saying, oh, you smoke and you're breathless, so that must be what you have. You will use pulmonary function tests to confirm or eliminate certain diagnoses and to assess severity. Arterial blood gases can be very important, both for severity and in the differential diagnosis. Certain illnesses would have blood gas derangements and others would not. And then there's actually a form of exercise testing called the cardiopulmonary exercise test, which can be useful in some cases of evaluating dyspnea. Well, that's the end of the entire chest examination lecture set. Thank you very much for your attention.